Hi, Chris.
Good morning, Dr. Fuster. How are you?
Yes, I'm fine.
Good,
Thanks very
good.
much.
Thanks for having me. Good to see you.
Yeah, very appealing picture. The fall,
I'm sorry, what's that?
your picture.
Oh, yeah.
Yeah,
All
Yeah,
right. Good morning, everybody.
those leaves have fallen, unfortunately.
yeah.
Good morning and Happy New Year to everybody. Um, Today, we're lucky to have Dr. Christopher Kramer giving us grand rounds. Dr. Kramer received his undergraduate degree from Harvard and his MD from UCSF. He then completed residency and a chief residency in internal medicine and a fellowship in cardiology at the University of Pennsylvania. His first faculty appointment was at Allegheny General Hospital, where he directed the cardiology fellowship program. In 1999, he moved to the University of Virginia, where he was named the George A. Beller Lantheus Medical Imaging Distinguished Professor of Cardiovascular Medicine and Chief of the Cardiovascular Division in 2019. Dr. Kramer's principal research interest has been in the application of CMR to the cardiovascular system, and he's published over 250 peer-reviewed publications, 4 books, over 100 book chapters, editorials, and reviews in the area of LV remodeling, viability, atherosclerotic plaque imaging, PAD, and hypertrophic cardiomyopathy. He has NIH funding for research in CMR PAD. He is the co-PI of a 2,700 patient, 44-site international registry of hypertrophic cardiomyopathy. He directs a T32 funded cardiovascular imaging fellowship training program. He's the treasurer-elect of the ACC. He has served as president of the Society for Cardiovascular Magnetic Resonance, chair of the Imaging Council of the ACC, and member and chair of the Clinical and Integrative Cardiovascular Sciences NIH study section. He's presently associate editor for imaging at JACC, a member of the editorial board of Circulation, Circ Imaging, and Vascular Medicine, and was until recently executive editor of JACC Cardiovascular Imaging. He's also a member of the American Society for Clinical Investigation, the Association of University Cardiologists, the American Association of Physicians, and in 2015 won the gold medal of the Society of CMR. So very privileged to have him here with us today. Welcome, Dr. Kramer.
Well, thank you for that very kind introduction. Sorry I can't be with you in person, but this is the state of the art in COVID. It's great speaking to you, including a number of friends from the Jack family, Dr. Fuster, Jagat Narula. Zai Fayad was a student when I was a fellow 30 years ago at Penn. And the group that actually was a site with us as part of the registry that I'm going to present to you, Bev Kim and Javier Sanz did the imaging on some of these HCM patients from your system. So without further ado, we'll get started. I will disclose that I have research grants and consulting agreements with Myocardia and Cytokinetics, who have new pharmacologic agents in this space. So I'm going to review the genetics with you, the pathology, focus on the imaging, the natural history and therapy of HCM. And then in the last half or so, we'll talk about the registry that I co-run along with Stefan Neubauer at Oxford called HCMR. So this is a typical pathologic specimen from a patient who died suddenly in HCM, and you notice the certainly asymmetric septal hypertrophy as well, but you also note that the lateral free wall is quite thick as well, and that's typical in many forms of HCM, that there is asymmetry, but there can be hypertrophy throughout. But there are a number of different forms that we'll talk about. There are no People toss about a number of terms to describe this condition, but most of them are specific to specific subforms. So the appropriate term to use is hypertrophic cardiomyopathy, HCM. You'll never be wrong if you use that term. If you say HOCM, you may be talking about some patient. Remember that only about 50% or 60% of patients with HCM have obstruction. So you may be talking about patients without obstruction. So it's better to use the term HCM. The disease process I will not be talking about today is hypertensive hypertrophic cardiomyopathy, the elderly, which is really an acquired condition. We're really going to be focusing on the genetic disease today. And speaking of genetics, this is a cartoon pulled from Barry Maron's review from a few years ago, showing that a mutation in any of the genes coding for the contractile proteins in the heart can lead to the phenotype of HCM. The most common of those being the myosin binding protein C in about a third, and the beta myosin heavy chain in another third. But you can see that basically any of the contractile proteins, the genes that code for them, can lead to HCM. Back in 2013, there were 1,400 mutations identified in these 11 genes, but since then, many more mutations have been identified as well. The numbers that are typically quoted are that the prevalence is 1 in 500 individuals, but it may actually be as high as 1 in 200 to 300 individuals, as it's being recognized more frequently with the advent of advanced imaging, as well as more frequent genetic testing. It's typically familial, autosomal dominant, and it's the most common genetic heart disease. It's characterized by unexplained hypertrophy, myocardial fibrosis, and as you can see from this figure taken from Hugh Watkins' review from about a decade ago, you see the pathology here. On the bottom right is a normal 4-chamber Cine CMR from a normal individual. On the bottom left is a patient with reverse septal curvature form of HCM. And when you look at the pathology compared to the normal, which nice striated cardiac muscle, you see myofibrillar disarray, as well as interstitial fibrosis, which is characteristic of HCM. It's associated with increased risk of sudden death and heart failure. In fact, it's the #1 cause of sudden death in young athletes. The pathology, as I've mentioned, is one of myofibrillar disarray, patchy interstitial fibrosis. The intramural coronary arteries are abnormal with periarteriolar fibrosis, and the mitral valve is structurally abnormal as well, which can contribute to some of the pathophysiology. That pathophysiology involves, in terms of obstruction, involves 4 interrelated processes: the obstruction, diastolic dysfunction, myocardial ischemia from supply-demand mismatching, as well as mitral regurgitation, due in part to the LVOT obstruction, as well as the intrinsically abnormal mitral valve. The physiologic consequences of obstruction in the patients with obstruction are elevated interventricular pressures, prolonged ventricular relaxation, increased myocardial wall stress, increased oxygen demand, and decrease in forward cardiac output, which leads to the symptoms of fatigue, dyspnea, and chest pain in HCM. Now, the ECG in HCM can present in a myriad of different ways. Here are a couple examples. A very common manifestation is severe left ventricular hypertrophy with repolarization abnormality, as shown on the top left. You can also see pseudo-infarct pattern, as shown here with Q waves in the infralateral leads because of the massive septal hypertrophy. So these are 2 of the more common findings you can see, but you can see almost any abnormality in varieties of HCM. The echocardiogram is obviously the go-to imaging modality as a screening test in HCM. This is on the left, you have a patient with massive septal hypertrophy shown here in diastole, and then at the bottom left in systole, you see the systolic anterior motion of the mitral valve and associated chordae that lead to the obstruction to flow. This is due to complex venturi forces from the flow along the hypertrophied septum that pulls the anterior leaflet of the mitral valve and the chordae towards the septum. Some of this is also due that the mitral valve is intrinsically enlarged in HCM. It's part of the pathophysiology. So that combination leads to the outflow tract obstruction. You can see continuous wave Doppler is in the top right, this late peaking dagger-shaped type of envelope that is pathognomonic of LV outflow tract obstruction in HCM. And quite commonly in obstructive HCM, you see this classic V sign with concomitant turbulence in the LV outflow tract from the obstruction, along with the mitral regurgitation here at a 90-degree angle that occur simultaneously, as shown in the color Doppler. This is a patient of mine who had very interesting obstruction almost in the mid cavity. You can see the chordal SAM way out to the mid LV wall here, and his septum measured about 1.7. You can see on the Doppler that the turbulence occurs very proximally here in the septum, and he was refractory to medical therapy, required myectomy, and the surgeon had to take out muscle down into the mid LV to really treat the SAM and obstruction that occurred there, and the patient's done terrifically well. He's a champion bass fisherman back to fishing. So there are a number of patterns of hypertrophy that one can see in HCM, and these are sort of the larger groups that we put together in this paper that was published in JACC a little over a year ago. So the two most common are A and B, A being isolated basal septal hypertrophy, and these are the patients that generally have most of the outflow tract obstruction. Patient B is a patient with what's termed reverse septal curvature HCM, where the thickest part of the septum is actually in the mid-septum, not at the base. Patient C has classic apical HCM, where the hypertrophy is limited to the apex. Patient D has concentric hypertrophy. Patient E has this interesting subform, which is mid-cavity obstruction with an apical aneurysm that in a number of studies has been shown to be quite high risk for ventricular arrhythmias and sudden cardiac death. And the latest guidelines is now a part of the, or an indication for an ICD, this particular subform, or one of the indications. And then patient F is a patient with what we termed other, and this patient has lateral wall hypertrophy asymmetrically. So these are the 6 major subgroups shown here on these 4-chamber Cine CMRs from our registry. Some of the first research work that I did as a fellow when I was at Penn was in HCM, applying a novel MR technique called myocardial tagging that was developed by Elias Zerhouni at Hopkins and simultaneously by Leon Axel at Penn, which was a technique to basically track myocardial deformation within the wall of the heart. In this patient with apical HCM, these black stripes are radio frequency and gradient pulses that null the signal in myocardium and diastole and allow you to track the deformation within the heart during systole. You can see in this patient with apical HCM that there's normal deformation at the base of the heart, but these tagged squares actually stretch during systole rather than shortening as they do at the base. There's actually stretching here. And we showed in this paper in Circulation, this dates me as one of my first couple of papers, you can see that there's reduced circumferential shortening throughout the LV in these patients with asymmetric septal hypertrophy in every segment except for the lateral wall. So let's move from the imaging to some discussion of the natural history, which has been remarkably consistent over the last 30, 40 years. In this study from JACC back in the early 2000s of 225 patients of mean age of 41, followed for over 30 years, And these numbers are very consistent from study to study. HCM, the annual mortality is about 1.3%. The annual cardiac mortality is 0.8%. And the sudden cardiac death mortality is about 0.6%. In this patient group, if there was greater than 50 millimeter of mercury LVOT gradient, a third developed heart failure, and in this study, syncope was identified as a sudden cardiac death risk. About the same time, Barry Marion published a study of 1,101 patients, only a quarter of whom had significant LVOT obstruction, followed for 6 years, and showed that LVOT obstruction was a risk factor for death with a 1.6-fold increase, and a risk factor for heart failure or stroke with a 2.7-fold increase. It was really not related to the severity of the gradient once the LVOT gradient was greater than 30. And this points out that LVOT obstruction is dynamic, and it can be a different minute to minute, hour to hour within a patient, depending on their loading conditions, what they had for breakfast, how far they're turned on their left side during the echo, how good the technologist is, et cetera, et cetera. So it's hard to follow these numbers. You have to take them with a grain of salt. And, you know, is 40 different than 55? Probably not. The important thing is that once the resting gradient is greater than 30 and the provocable gradient is greater than 50, that changes the prognosis. The absolute number doesn't matter as long as it's over that threshold. And this slide points out the prognostic importance of LVOT obstruction. So this is data from Steve Alman at the Mayo Clinic, published in JACC in 2005. Blue are patients without obstruction, and the y-axis is freedom from progression to class 3 or 4 heart failure and death from heart failure or stroke. And red are patients with obstruction. You can see that there's a much worse prognosis in terms of heart failure and stroke in the patients with obstruction. On the right, if you take the patients with obstruction who are now in purple and do myectomy, now in red, you can see that you return the prognosis of the obstructed patients with myectomy. You can superimpose the line on patients without obstruction. Now, this is not a randomized study. This is observational. It points out that relieving obstruction is an important part of altering outcome in HCM for those with obstruction. Another important point is that the age of diagnosis is important and points to the severity of disease when identified. So this is data from the SHARE registry led by Carolyn Ho, which is a registry of over 6,000 or 7,000 patients, multi-center, really focused on the genetics. But what they've shown is that the overall composite outcome is much worse when the patients are diagnosed before the age of 40 compared to 40 to 60 as compared to when diagnosed greater than 60. So if you're diagnosed at 65, your prognosis is not that of a normal individual, but it's certainly not that of a patient who was diagnosed at age 20. And the same is true whether the part of the composite that represents midventricular arrhythmias, heart failure, or atrial fibrillation. Age of diagnosis is an important factor. So how do we evaluate a patient who is sent you for evaluation for hypertrophic cardiomyopathy? Well, we start generally with an echo. In general now, in every patient, we will do a CMR, and I'll discuss more why that is in a moment. Generally, we do a Holter monitor looking for ventricular arrhythmias. We often do an exercise ECG, looking for not only arrhythmias, but exercise tolerance, as well as blood pressure response. And we have our genetic counselor see the patient, discuss screening of first-degree relatives, as well as the benefits of genetic testing. So what about therapeutic options in HCM? Well, this is a rapidly evolving field. For the first time in over 3 decades, we have new therapies in HCM that are showing promise. So, but the drug of first choice presently are beta blockers, as they increase diastolic filling, relaxation, reduce oxygen consumption, but don't think you're changing the incidence of sudden cardiac death with beta blockers, because you're not. An alternative to beta blockers and those who can't tolerate it are calcium channel blockers. Sometimes we add them on top of beta blockers if there's room. Often the pulse rate limits you unless there's a pacer as a backup, but often sometimes we can combine beta blockers and calcium channel blockers. In patients who fail with obstruction, now we're talking about patients with obstruction and symptoms, patient who fail these two therapies, second line therapy at present is a drug called disopyramide or Norpace, which is really an orphan drug. It's a type 1C antiarrhythmic that was developed but really thrown away eventually because it caused negative inotropy. Well, that's its benefit in HCM. So it's a second line therapy in patients who fail beta blockers, calcium channel blockers because of its negative inotropy. It can be difficult to tolerate in some patients, and it's only modestly effective. In my hands, I'd say a third can't tolerate, another third, it isn't that effective. And so it's really about a third of patients that you can really stave off invasive interventional therapy for obstruction with Norpace. But there are emerging therapies, and one, the first of these is a drug called mavacamten, developed by MyoKardia. It's a direct allosteric myosin inhibitor, so it intercalates into the contractile apparatus and is really a targeted negative inotrope. And this is data that was presented at the European Society of Cardiology and subsequently published in Lancet just a couple of months ago. It's a phase 3, FDA phase 3 study of mavacamten in obstructive HCM. It's also been studied in phase 2 in non-obstructive HCM, where it was not shown to be quite as effective, but it's certainly shown to be effective in this study in obstructive HCM. So there was an interesting composite functional outcome in this study, which required both improvement in a New York Heart Association class as well as improvement in VO2. In terms of the functional outcome, it was twice as good in the patients with mavacamten as placebo. Well, you might say, well, only 37% of patients completed the composite functional outcome, which is true. The problem with the composite outcome was that improving VO2 when you're on a beta blocker, and all these patients had mavacamten added to beta blocker, or 90% of them did, it's very hard to increase your VO2 on a beta blocker because it requires increase in cardiac output, which is difficult to do. So this was not the best outcome measure to be chosen. But if you look at some of the secondary endpoints, you can see that the peak gradient post-exercise fell by 47 millimeters of mercury in the treated group, only by 10 or 11 in the placebo group. The VO2 did increase slightly in the treated group, didn't change in the placebo group, and 2/3 of the patients in the mavacamten treated arm improved their New York Heart Association classification by 1, compared to about 1/3 in the placebo group. So really the first new therapy in HCM that's been shown to improve symptoms in patients with obstruction. There's a second drug in this class being developed by another company, Cytokinetics, that's now entering phase 2 studies. So there'll be additional therapies in this space coming to your pharmacy within this calendar year. Most likely mavacamten will be up for approval by the FDA. So in patients who fail the medical therapy for obstruction, I just mentioned earlier, surgical septal myectomy, which is really the interventional therapy of first choice in US guidelines. In Europe, it's second choice. I'll talk about the first choice in Europe in a moment. But what the surgeon will do typically, depending on the site of obstruction, is basically resect the most basal form of portion of the septum, allowing increased outflow. Sometimes they will concomitantly repair the mitral valve, but often just the myectomy alone will treat the SAM and outflow tract obstruction. It's very effective therapy, especially in hands of surgeons who do it quite frequently. You don't want to have it done in a center where they're only doing a couple of these a year. The therapy that's chosen first in Europe is alcohol septal ablation, where the interventional cardiologist will thread the catheter into the first and/or second septal perforator, inject alcohol, blow up a balloon, inject alcohol, basically create a controlled infarction of the basal septum that then involutes over the next several days to weeks, reducing the outflow tract gradient. And this is quite effective as well. We really reserve this therapy for patients who are poorer candidates for open myectomy. These then tend to be elderly patients, patients with extensive comorbidities, and that's how we approach these patients at UVA. And this is basically a summary of the therapeutic algorithms from the Marin Lancet paper in 2013. Once mavacamten is FDA approved, this can be added to this algorithm. But presently, if the patient's genotype positive, phenotype negative, there's no specific treatment. There have been studies of therapies to try to delay the onset to phenotypic positivity that have not shown benefit. Patients without symptoms, you can't make an asymptomatic patient feel better, so there is no specific therapy. We'll talk more about sudden death risk in a moment. AFib and stroke, we treat HCM patients similar to any other patient with AFib in terms of rate control, antiarrhythmic drugs, and anticoagulation. Most importantly, heart failure symptoms. If the EF is less than 50, that's considered end stage in patients with heart failure, and they're treated as if they have end stage heart failure. If with preserved EF and heart failure symptoms, we talked already about the outflow obstruction. If they fail medications, myectomy. If there's lower outflow gradients or with exercise, we again start and continue with drug therapy, the drugs we've already mentioned. So talking about sudden death, the current sudden cardiac death risk predictors, and I left one out on the slide that was just added in the recent update of the guidelines that came out last month. But the present risk factors are family history of sudden cardiac death, syncope, massive increase in wall thickness, non-sustained VT, hypotensive response on a treadmill test, and then you can add the mid-ventricular obstructive form of HCM with an apical aneurysm as another SCD risk factor. But limitations that these only predict sudden cardiac death, they don't predict heart failure. And the majority of events occur in those with either 0 or 1 of these risk factors, and thus it represents the tip of the iceberg. The Europeans have come up with a sudden cardiac death calculator that includes some of these that were listed from the US guidelines, namely family history of sudden cardiac death, non-sustained VT, and unexplained syncope, and then some quantitative data that can be obtained from history and the echo, including wall thickness, LA size, and LVOT gradient. And then this will spit out the estimated risk of sudden cardiac death at 5 years, and the ESC will recommend whether or not that patient deserves a device. And this algorithm was attempted to be validated in this study in circulation in 2018. And what was shown is when you look at the observed versus predicted rate of sudden cardiac death, that it did well in the lower risk patients, but it actually overestimated risk in the intermediate and higher risk patients. So there's clearly room for improvement in terms of risk calculation. The other problem with sudden cardiac death prevention in HCM is that this is an older study, but that you're putting ICDs often in young patients, and they have to live with them for 50 years. So you really don't want to put in devices inappropriately, because in this study from Barry Marin, appropriate therapy for primary prevention ICD was used in 17% of patients over 5 years, but there was a higher incidence of inappropriate shocks and complications. Now, this is an older study, older devices, but suffice it to say, one has to be very aware of the potential complications of ICDs in these patients. Now, subcutaneous ICDs may be changing this overall balance and with a reduction in the complication rate, and so that may actually change the utility here. I want to spend a couple minutes talking about the use of cardiac MR in HCM. Let me start the movie again here. This is a patient with reverse septal hypertrophy. He also has apical hypertrophy as well. This is a 4-chamber cine. CMR has become the gold standard for measuring LV mass, volumes, and 3-dimensional assessment of location and extent of hypertrophy. We can measure some of the same things that's done by echo, although echo is probably still the gold standard for measuring outflow tract gradient and mitral regurgitation. But and CMR, as I mentioned, is the gold standard for measuring LV mass, and that's important in HCM, as shown in this paper by Jacopo Alivoto, that if you markedly increased LV mass, the outcome is worse compared to those with either normal or mildly increased LV mass. But most importantly, with CMR, we can measure fibrosis or scar. This is images from 6 different patients with HCM. Patient A, and this technique that we're using here is late gadolinium enhancement. We inject gadolinium and 10 to 20 minutes later, image and areas of normal myocardium appear dark. Areas of scar appear bright because of increased volume of distribution and delayed washout of the contrast from the scar. Patient B, so patient A has no scar. Patient B has this confluent anterior wall scar, but subendocardial sparing, which tells us this is not a myocardial infarction. And then this patchy mid-wall enhancement here in the infraseptum. Patient C has the classic form of RV insertion site scar in HCM, shown also in patient E. And patient F has diffuse LGE in this markedly hypertrophied aneuryseptum. Turns out somewhere between 0.5% and 60% of patients with HCM have any LGE, so we really can't use that alone as an indication for an ICD because it's so prevalent. And recall that the sudden death risk is less than 1% per year. So you would be putting in way too many defibrillators if you use the presence of scar as an indication. Scar is certainly a risk factor for adverse outcome in HCM, as shown in this meta-analysis published in JACC Imaging in 2016, with a 1.8-fold increase in all-cause mortality. This is a meta-analysis of over 3,000 patients, a 3-fold increase in cardiac death, a 3.4-fold increase in sudden cardiac death, and a 2.2-fold increase in heart failure death. So clearly, the presence is a risk factor. But even more importantly, it turns out that the extent of scar is an important risk factor for sudden cardiac death, as shown in this paper from Chan and Marty Marin and colleagues in Circulation a few years back now. What they showed is that there's a threshold above about 15% of LV mass, when the LGE extent is more than 15% of LV mass, that the incidence, the freedom from sudden cardiac death event is reduced. And you can see, so from about 1% per year, if it's over 15% LGE, you get about 2% per year sudden cardiac death risk. And you can see the stepwise increase in sudden cardiac death events as the percent LGE increases from left to right here. Briefly, the other thing we can measure with CMR is interstitial fibrosis. And just a cartoon to show how T1 mapping is used to measure interstitial fibrosis. This is a cartoon of normal myocardium in the left, hypertrophied myocardium at the bottom left, with the lacy interstitial fibrosis as blue. When we give gadolinium, gadolinium is a T1 shortening agent. In normal myocardium, if you image 10 minutes after contrast, there's very few molecules of gadolinium left. In patients with extensive interstitial scar, there's more gadolinium here caught up in the fibrosis, and gadolinium is T1 shortening. So if you measure the T1 quantitatively, you can measure reduced T1 in the myocardium of, post-contrast in the myocardium with patients with HCM. There's also something called native T1 mapping, where measuring the T1 before you give contrast in patients with HCM, the native T1 is actually increased, as shown in this paper from Oxford. In terms of post-contrast T1 mapping, we can use pre and post-contrast T1 mapping together to measure what's called the extracellular volume, which is the percent of the LV that's subtended by interstitial fibrosis. In you or I, that percent is about 25%, and it's a very tight number. 26% of controls have the ECV is that number. In genotype positive, phenotype negative HCM, the number is around 30%, and somewhere between around 35% in patients with phenotypic HCM, as shown in this paper from the Brigham group in 2013. And the numbers from our registry are a little bit lower than this, but suffice it to say, the extracellular volume in HCM is increased. The presence of a genetic mutation is also a risk factor, as shown in this data from the SHARE registry, that if you take HCM patients at risk with a clear-cut sarcomere mutation, that once your age is over 40, compared to the US population, your risk of death increases substantially over 50 and 60. Whereas if you have non-familial HCM, there's certainly a trend to increase risk, but didn't reach statistical significance. So the presence of a sarcomere mutation is another risk factor for death in HCM. And collagen biomarkers may be important, as shown by the Brigham group preliminarily, that the N-terminal propeptide and C-terminal propeptide, or PICP, which is a collagen degradation marker, is shown to be increased in patients with overt HCM. And we're studying it in our registry. And other biomarkers may be important. This Japanese study of over 300 patients with HCM, elevated troponin was noted to be a risk factor for cardiovascular events. So we decided to put all these various risk markers together in a large registry and try to put this together and try to understand what really are the most important risk factors for both sudden cardiac death and heart failure. So Stefan Neubauer and I put together this U01, and we're funded by the NIH back in 2013. This is the website if you'd like additional information. And the goal of the registry was to change the existing paradigm in HCM by improving risk stratification, identify risk predictors, surrogate endpoints, and be able to design studies in the future more effectively. So we set out to recruit 2,750 patients, mean age of 18 to 65. We didn't go over 65 because they're competing risks for sudden death in terms of coronary disease and other cancer, et cetera, over age 65. So we cut it off at 65. Patients, this is not a screening study. Patients had the established diagnosis of HCM. We planned a 2-year recruitment phase. We recruited 44 sites in North America and Europe with dedicated HCM centers and CMR capabilities. We planned a 5-year study, but it's gone beyond that, as it took an extra year to do the recruitment. The plan was to develop a score from the predictive model that we developed that could be used to assess risk given a patient's combination of risk factors. So the idea was at the end of the study, you would have a smartphone app similar to the SDS risk score that you would put together all your patients' data and come up with a 5 or 10-year risk of sudden cardiac death and heart failure. The endpoints that we're measuring are cardiac death, both sudden cardiac death and heart failure death, aborted sudden cardiac death. Now, ICDs were, patients with ICDs were not entered into the study because at the time we were doing the CMR, we didn't want to include ICD patients, not because it wasn't safe, but because some of the data we were collecting may be been altered by the presence of the ICD. So, but if the patient got into the study and then had an ICD placed, we're including appropriate ICD discharge as a primary endpoint, and then the need for heart transplantation, and then a host of secondary endpoints as well that are common in HCM. Exclusion criteria were patients with known CAD or prior MI, prior interventional therapy of their septum, known contraindication to contrast-enhanced CMR, incessant VT, end-stage diabetes or pregnancy. So back in 2015, we published the methods paper that put together how we designed the study and what our plans were. In terms of the CMR, we performed cine imaging as described for LV mass, morphology, and mitral regurgitation. We performed late gadolinium enhancement to assess the fibrosis both the extent and pattern, and also did extensive T1 mapping to measure diffuse interstitial fibrosis. This was the protocol. After localization, we did native T1 mapping, we did our cine imaging, we did post-contrast T1 mapping to measure extracellular volume, and then did our late gadolinium enhanced imaging. Our genetics was led by a core lab at Hugh Watkins at Oxford, and they performed next generation sequencing and analyzed complete coding sequences and flanking splice site sequences, looking for known sarcomeric HCM genes as well as clinically related disorder genes. Carolyn Ho at the Brigham runs our biomarker core lab, and all of these biomarkers were measured, including the PICP measure that I mentioned earlier, as well as BNP and high sensitivity troponin. This is the executive committee of HCMR, Stefan Neubauer and myself. Bill Weintraub at MedStar Clinical Research Institute runs the Data Coordinating Center and now also the CRO, Hugh Watkins and Carolyn Ho, and then a host of CMR investigators as well. The NHLBI is on our executive committee because it is a UO1. The 44 sites that we recruited included 22 in Europe, half of those in the UK, and then 22 in North America. You can see there was a Northeast predominance. We completed enrollment in April of 2017, overshot a little bit, and ended up with 2,755. It took us 3 years to enroll as opposed to the planned 2-year enrollment. And you can see that Europe and North America recruited in the end just about the same numbers of patients. This is, I don't mean for you to read this slide, there's too much data here, but this is the baseline information about these 2,755 patients that was published in the JACC paper in 2019. Mean age is 49, 71% male, 16% minority, they were overweight, 30% had a first degree relative with HCM, and about a third had a concomitant hypertension. In terms of the CMR cine data, LV mass index was elevated as one would expect, and the ejection fraction was normal. And that was, we again excluded patients with heart failure in the study. So we expected a normal EF. In terms of late gadolinium enhancement, 50% of patients had any LG, as I mentioned, that had been shown in prior studies. In terms of associations of the presence of late gadolinium enhancement, turned out lower body mass index, family history of HCM, increased maximal wall thickness, the presence of an EF less than 55, a history of arrhythmias at baseline, either AFib or non-sustained BT, and interestingly, a presence of a sarcomere mutation positivity, which was seen in about 36% of patients, was also associated with the presence of LGE. Very interesting was the association of LGE presence with the morphology, and not just presence, but extent, with the morphology of the HCM. So it turned out in patients with isolated basal septal hypertrophy, 2/3 of those patients had no LGE, and those who did have any LGE, there was not very much, less than 5%. Where if you look at the patients with reverse septal curvature, this form of HCM, which is more commonly associated with the sarcomere mutation positivity, only a third had no LGE, and they represented the vast majority of patients with extensive LGE, more than 10%. So the reverse septal curvature patients, who these represent about 40% of patients with in our registry, and the isolated basal septal hypertrophy patients represented about 40% of the patients in the registry. So together, about 80% of the patients in the study had one of these two forms of HCM, very different in terms of the extent of scar in these two subpopulations. In terms of T1 mapping, we were able to measure it in about 3/4 of the patients. About a quarter of the sites either didn't have the appropriate software, et cetera, but 3/4 of the patients we were able to do it. And what we showed was that the ECV is certainly elevated over controls, about 28% in the patients without LGE, about 30% in those with LGE. Remember, normal is about 25%. And ECV is higher in females than males, and that's a known quantity. Higher extracellular volume was associated with some of the same risk factors as the presence of macroscopic scar LGE. So interstitial fibrosis and macroscopic scar have some of the same risk factors. There were interesting differences in terms of the presence of a sarcomere mutation. Those patients with a sarcomere mutation tended to be younger, thinner, less commonly male, less commonly minority, more commonly a family history of HCM. Interestingly, less commonly had a significant LVOT gradient and less commonly had hypertension. When we looked at the combination of genetics and late gadolinium enhancement, this may reflect back again about the reverse septal curvature form of the disease, that if you had a sarcomere mutation positivity, only 30% had no LGE, and you can see that there's this significant LGE extent in the rest. In the patients with sarcomere mutation negativity, 60% had no LGE. So the presence of a sarcomere mutation positivity both predicts the presence and extent of scar in the heart. Interestingly, there was a stepwise increase in biomarkers in patients with scar. You can see that as you increase the percent LGE, both NT-proBNP as well as troponin T increase stepwise. And so it will be interesting in the end to see if one or more of these markers predict outcome in HCM. So this is our summary slide from our JACC paper, in which we, in our 2,755 patients, identified two broad, relatively distinct populations. One group were sarcomere mutation positivity, more likely had the reverse septal curvature morphology, had more LGE and interstitial fibrosis, and less LVOT obstruction. Compare that to the other large subgroup of patients who are sarcomere mutation negative, isolated basal septal hypertrophy, less scar, and more obstruction. So food for thought in terms of thinking in our own minds about subgrouping patients with HCM and thinking about differences in both symptomatology, more obstruction, versus sudden cardiac death risk, more scar. So we'll have to see how this plays out as we continue to follow these patients. We have additional ancillary studies ongoing. One is of strain led by Raymond Kwong at the Brigham. We're measuring longitudinal, radial, and circumferential strain from feature tracking of our cine imaging. And they've shown, at least preliminarily, interesting differences in strain depending on the HCM morphology, showing more preserved strain in the isolated basal septal group and the worst strain in the apical aneurysm group. And that's consistent across the longitudinal, circumferential, and radial strain. Our endpoint committee is led by John DeMarco at UVA. And we have experts in both EP and heart failure assessing endpoints as we collect them. As of September, we're at about a mean of 3.3 years of follow-up, had a total of 55 events. We're aiming for about 100 events to be able to have a robust model to predict the primary outcome. So we still have a couple more years to go to reach this 100 event threshold. We've had 27 cardiac deaths, 22 cardiac arrests or appropriate ICD therapies, 5 heart transplants, and 1 LVAD placement. Our most frequent outcome event is AFib requiring therapy, and I'll spend a minute talking about this. This was presented at last year's ACC, and it's now in presence of submitting it to JACC EP. So the predictors of AFib burden is what we presented. we excluded 77 patients with persistent AFib. A few had missing data, ended up with 2,731 patients with a mean of nearly 3 years of follow-up. We had 127 AFib events in 96 patients. AFib events in this study were not stroke, because we couldn't say for sure whether that was due to AFib, but more clinical events requiring therapy, cardioversion, ablation, 24-hour hospitalization, or leaving the patient in persistent AFib. We put 46 variables into elastic net model and found that predictors of the time to first AFib event were some predictors that had been shown in prior studies, age and obesity, but importantly, measures from the CMR, LV volume index, and left atrial contractile percent. So the higher volume index was a risk factor, better contractile function of the left atrium was a protective factor, especially in older patients. And as one might expect, mitral regurgitation was a risk factor for AFib as well. So in conclusion, our registry, HCMR, has the potential to identify important new risk factors in HCM and really put them together comprehensively and improve prognostication, identify targets for novel therapies. We have a couple more years to go to complete the follow-up, to have enough events to develop this predictive model. So watch this space in the years to come. With that, I'll end, and thank you for your attention. I'm happy to answer questions.
Yeah. Dr. Kramer?
Yes.
Can you tell us, the European model looked at, also the left atrial volume index. It also looked at the wall thickness, and it looked at gradient. Are you including those variables as well?
Yeah, so
hypertension?
we are using that. We have all these variables, right? We have echo measures as well as CMR measures. So we can see what will fall out as the most important predictors of outcome. Is it, wall thickness by echo, wall thickness by CMR? Is it gradient? Is it scar? And what it most likely will be is a combination of risk factors. No, there is no one risk factor in HCM that trumps all. It's likely going to be a combination. And so we hope to come up with a risk model that outperforms the ESC risk model, because as you recall, the ESC risk model doesn't include information about scar, which we think is probably very important. It doesn't include information about biomarkers, which we suspect is likely to be important. And it doesn't include information about the presence of a sarcomere mutation, which we expect to be important. So we think the genetics, the scar are going to be added, and biomarkers are going to be additive to the models that have been used to date. And that's really the power of this registry, is that we measured all these variables in one place, whereas other studies and other registries have looked at either genetics alone or echo alone or whatever. And so in this study, we really have all of the data in one place and can really pick out which are going to be the most important.
Another interesting group is the genotype positive, phenotype negative. Are you following any of those patients for rate of progression or conversion?
No, we really aren't. We only included phenotypically positive HCM patients in the registry. So we did not include genotype positive, phenotype negative patients. Their event rates are very low. Already in HCM, the event rate is only 1% per year. So that's a low event rate. And then you take phenotypically negative patients, their event rates are exceedingly low. So you have to follow a huge cohort of those patients for 30, 40 years to really glean anything. So that was really not within the scope of our registry.
Chris, Valentin, I'd like to ask you a question. as an imager who has contributed so much on the fibrotic process, give us a sense of the next few years in terms of MRI and the quantification of the different type of fibrotic tissue that you mentioned. And I'm talking not only about the ventricle, also about the atrium and the atrial fibrillation and so forth, because it seems to me this is a big, big advance in the field.
Yeah, I think, to start out in, so to broaden the scope here to not just HCM, cardiomyopathies in general. I mean, CMR has really made incredible inroads in being able to differentiate the cause of the cardiomyopathy in the setting of non-ischemic cardiomyopathies. Differentiate, sarcoid amyloid, HCM, and just identifying scar as a prognostic marker, even in non-ischemic dilated cardiomyopathy. So that's, it's incredibly important in terms of predicting outcome, sudden cardiac death, et cetera. The studies are ongoing as to understand whether both presence and extend in various diseases can be used as an indication for an ICD. The issue of left atrial scar and predicting AFib is an interesting one. It's, it's a tricky area. I think in LV scar, we do really well. I think we're still learning how best to image left atrial scar. The left atrium is a very thin structure, as you know, a couple millimeters thick. So being confident that one is truly measuring late gadolinium enhancement of the left atrial wall is difficult. I think we are looking at that. The Hopkins group is analyzing our LGE data to understand if we can use this as a marker. I think we'll watch this space. We'll have to understand how good we are at measuring fibrosis in the left atrium. I think we're still just scratching the surface and don't really understand how well we can do it with CMR. So some of the early studies, MESA, et cetera, the data is a little bit messy. And so I think we'll have to see how the imaging improves over years and also see how well we can use it as a prognostic marker for AFib.
Thank you.
Any other questions? Again, thank you very much, Dr. Kramer. It was really excellent, very comprehensive talk and exciting new data. And we look forward to the new data as it comes out and hopefully have you back again live. Thank you again very much. Have a great day. Happy healthy New Year to everyone.
Thank you very much for having me.
Thank you very much. It was wonderful talk. Thank you.
Thanks. Take care. Have a good day, everyone.